Medurstand-Understanding Medicine.
Professor Aziz Rehman here in our series of lectures on Introduction to Clinical Medicine. This is the third one, and today we'll focus on physical examination. And before we start physical examination, I will present the recap of the last lecture, which was on history. First of all, we record personal profile, which includes patient's age and gender and date of birth and address and maybe phone number, just to identify that person. And then we note down the presenting symptoms. I told you there could be 1 or 2 or 3 or max 4. And you just list the name of the symptom and the duration. Further details are given in the history of present illness. The history of presenting illness, including systemic review, this is actually elaboration on presenting symptoms one by one in the form of paragraphs, and at the end in the systemic review you tell that everything else is okay, patient does not have any additional symptoms. Then all types of histories like past history, family history, personal history, social history, history of medication, adverse drug reactions, vaccination, menstrual histories, or any other history which could be medically relevant. So this would complete the history part of our document, but actually I think there's one more, that is patient's ideas, concerns, and expectations. So I think we need to know what the patient actually came for. Of course, he or she wants to have the diagnosis, relief of the symptom, but there may be certain ideas and concerns and expectation patient wants to share. Today we will move on to physical examination. Now, physical examination is actually you examine the patient in a formal way, in a systematic way, and I'm going to present that. I'm sure you already know it, but just to complete the module, I'm going to present this. But please note down that this is only going to be an outline, because I will not be able to go into the details of every system, because that will be covered in separate modules. So equipment you need for physical examination is, number one, a stethoscope. Stethoscope is actually a sign of being a doctor. So I think it is a matter of pride to carry a stethoscope, and you must know your stethoscope and you must learn the proper usage of stethoscope. And blood pressure apparatus, it may be available in your clinic or in the departments, but it is a good idea to carry one with yourself. And a torch, previously we used to carry a torch, but these days I think there's a built-in torch in our mobile phones, and practically everybody carries a mobile phone, so I think torch part is solved. Then a measuring tape is very good. Sometimes we have to measure the waist circumference, or sometimes you have to measure girth of one limb with the other one, and sometimes you have to measure the expansion of chest. So measuring tape is also very handy. A hammer to elicit reflexes. This is very important in central nervous system examination, and central nervous system examination cannot be performed without a hammer. And then a tuning fork, not necessary, but I think it would be good if you have one. And then you would actually need two tuning forks, one for the checking the sensations and the other one for the checking the hearing. I said both have different frequencies. And above all, I think most essential tool you need to have to be able to conduct a good physical examination is a common sense, a patience, and a kind heart. So you need to be equipped with these three things to be a good physician and to be able to conduct a good physical examination without harming the patient and coming back with good physical finding, which will lead to a good diagnosis. So let's move on. Formal examination is typically done after you complete the history. But I think but we start making impressions the moment we encounter the patient. For example, you are sitting in the room and patient is brought in. and the patient is clearly short of breath, or patient is brought on a wheelchair and you can see that he's not well, or patient is brought on a stretcher with broken leg, or maybe patient is got having seizures. So I think some physical examination starts before you start history taking, and informal physical examination continues throughout your history taking because you're observing the person. But formal systematic examination typically starts after you have taken the history, because patient wants to communicate with you verbally before you approach him for the examination. So there are two types of examinations. What students are taught, that is stereotyped physical examination. That means they have to examine everything from head to toe and in a proper systematic way. Reason is that in third year, for example, when you have first clinical encounter, so we don't expect that you will be able to immediately figure out what is relevant and what is not. So I think you would consider every possible thing relevant to the history. So you would do the stereotype examination as I'm going to outrun here. But as you get experience, then you can adopt another approach that is called a tailor-made approach. For example, if you have figured out from the history that this patient has got, say for example, bronchial asthma, your examination can be modified to pick up everything relevant to bronchial asthma to save time, and rest of the things can be done later or not at all. So I think this is the difference between stereotype examination and tailor-made examination. And the reality is that as we become more and more experienced, we are adopting more and more tailor-made examination. This may be actually good for the patient also, because physical examination may be tiring for the patient also. So I think that is why when appropriate, you should adopt this tailor-made approach. So physical examination, first part is general physical examination. So as the name says, it is general examination. You basically inspect the person and also touch the different parts from head to toe. And this is, I think, like examining something under the microscope in the low power field. Low power field will give you a broad area of vision but will not give you the depth. So I think a general physical examination from head to toe, you actually examine everything and then you examine everything systematically. So then systematic examination or systemic examination. Systemic examination means that you examine every system. We have arbitrarily defined, classified body into different systems, divided into different systems. Although body is a one whole, one functional unit, but we have divided it into different functional units to do the examination. So what is the scheme of physical examination? First, physical examination, and then in the physical examination, general physical examination, and in that you take vital signs. Now, what are the vital signs? Traditionally, we take pulse, and we measure blood pressure, we measure temperature, and we count respiratory rate. These four things, which can be precisely measured and recorded, are called vital signs. Why they are called vital signs? Because if all these four are stable, I think you can be reasonably sure that patient is stable, patient is not critical. And if patient becomes critical, these vital signs will be affected. Okay, so that is why we call them vital signs. So all those patients who are admitted and who are potentially serious, they must have all their vital signs recorded, and in fact they are actually monitored on every visit. So on every round, in the morning, afternoon, evening, and nurses, they record the vital signs. Then we examine the whole body from head to toe. In systemic examination, we have divided the body into different systems. There could be cardiovascular system, which includes the detailed examination of pulse. In general physical examination, we just count the rate and rhythm. But here in the pulse, we would examine it in more detail, which will be covered in CVS examination. And then we take blood pressure, and then we examine neck veins, and then we come to the precordium. First we inspect precordium, then we palpate it, then we percuss it, and then we auscultate it. That completes examination of cardiovascular system. Next is a respiratory system. In respiratory system, you may start with the examination of hands to make sure there is no cyanosis, and then you look at the chest, and then inspection, palpation, percussion, and auscultation. And you also examine the trachea. So that will complete the respiratory system. Then in GIT, in gastrointestinal system, you examine the abdomen, and preferably abdomen should be exposed. And it is always emphasized that genitalia and inguinal region that is included in GIT. So I think first you can inspect the abdomen, and then at the end, I think you may gently ask the patient to expose the concerned area and then examine that also. Remember, you must provide privacy to the patient. Then is the central nervous system examination. This is the most, I think, painstaking examination, but very rewarding. And it has got different examination techniques. CVS, respiratory system, and GIT, they have simple inspection, palpation, percussion, and auscultation, but CNS has got a different way of examination. And we start with the higher mental function, and then we do the cranial nerves, then we do the motor system, then the sensory system, and the reflexes, and the cerebellar system, and then we see for the signs of meningeal irritation, and then some special tests. So this will complete the CNS. Now, in some cases, depending upon the nature of the history, there may be other systems which may be needed to be examined, like musculoskeletal, skin, and appendages. So there may be other systems also. Now, I think one thing I always ask my students, which of these 4-5 systems should be examined first of all? There is no rule, but I think common sense says that the system to which symptoms belong, that should be the first one to be examined. For example, if somebody has abdominal pain, nausea, vomiting, diarrhea, I think it is best to start with gastrointestinal system. Why? Because patient would find it most relevant and will be satisfied, and you will have the best use of time on gastrointestinal tract, because you know that the findings are expected here. And anything else which could be related. For example, somebody is having severe diarrhea and vomiting, then of course you would like to know the blood pressure, the cardiovascular system. So everything else will also come into, will be concerned, will be relevant. So I think the system which is apparently affected should be the first one to be examined, but in all cases, all systems should be examined. Why? Because some very important physical finding may come from another system which apparently is not affected. For example, patient says shortness of breath and there's pallor, but when you examine his abdomen, you find massive splenomegaly. Patient never mentioned about any pain here or moderate splenomegaly, but that splenomegaly actually provides very, very important clue to the diagnosis. So examination should be complete. Another point I think I like to tell the students especially, that whole physical examination does not need to be necessarily completed in one go. If you see that the patient is tired, and if you are tired, and if you don't have time, then you can of course stop the examination there, and then at the later time come and resume your physical examination, so that you take complete history and complete examination. In general physical examination, these are the things I've already mentioned: pulse, just the rate and the rhythm, blood pressure, there is a specific way of measuring blood pressure and you need to learn. We may use digital apparatuses which are automatic, or you may use the mercury one or any one. But there is a specific method and there's certain precaution. And some of the precaution I must tell here. Patient must be resting for 5 minutes. So that is why we take blood pressure reading after we complete the history. And ideally patient should be sitting up on a chair or a stool with backrest. Legs should be hanging and feet should be rested on the floor. And patient should be physically, mentally relaxed. The temperature should be comfortable, no very hot or cold temperature. And then you expose the arm, and where the part of the arm where you apply the cuff should be at heart level. In upright sitting position, that would be actually at the heart level. And you measure the reading with a calibrated blood pressure apparatus with good cuff. Cuff size should be according to patient's arm girth. So there is a different cuff size for children, was very small children and very frail people, and standard cuff, and then the big cuff for big people. So if the first reading is clearly normal, I think you could just write it down. But if it is borderline or high, it is recommended that you take another measurement, maybe in the other arm, and you take reading maybe after a few minutes. So in some cases, initial high readings would actually settle down. This we call it white coat hypertension. But I think even if one reading is high, that needs to be addressed, because these patients, they are likely to develop persistent hypertension later. Respiratory rate, you measure respiratory rate. Now it is very important that when you measure respiratory rate, patient becomes conscious. And I think my technique is that I hold the pulse, and then when I examine the pulse, that I pretend that I'm taking the pulse, but I'm actually concentrating on patient's respiratory rate, and I'm looking at the patient's breathing pattern. Then finally you check temperature. I think mercury thermometers are now going away because of the risk of mercury. These days we use digital thermometers. Now when the thermometer is being shared, I think it is then best to wipe it with alcohol and put it in the axilla under the clothes and wait till it gives you the beep. It's not just 1 minute or 2 minutes. When thermometer gives beep, then you take it out and record the temperature. Now I didn't give you the details of pulse. Let me give you it now. You hold the arm in a way that arm is relaxed, and typically we use our left hand and we put it on the radial artery. Why? Because radial artery is superficial and is easily palpable. And since you have to measure the heart rate also, and you have to look at your watch, and mostly we wear our watch on the left wrist, so it will be very convenient to hold the arm like this and measure pulse. But when you go to a cardiovascular system, you will measure pulse in all palpable arteries that I will cover later. So these are the vital signs. They are to be recorded at the time of presentation, and then in the every visit, every time you see the patient. So in physical examination, general physical examination, first impression. Now for students, I think it may not be easy to make an impression, but I think an experienced person will immediately make some impression about the patient even before you take a history. The overall looks of the patient, does patient look very ill or very sick or very toxic, or does he look quite all right? So I think first impression, and then you start with the examination of hands. You could actually start from anywhere, but I believe when you touch somebody's body, I believe hands are best part to start with, because we normally, when we interact with each other, we shake hands. So I think it would be best to start with the examination of hands. When you go into the detail, there are many things, but I think mostly you look for clubbing, you look for koilonychia, and you look for cyanosis. These are three things you must look at the hands. Of course, any obvious deformities and atrophy and the other things discoloration, that will be also noticed. Then you come to the face, patient's expressions. Does patient look ill or not? Complexion, pale complexion, yellow complexion, or cyanosis, or jaundice, or overall facies. Sometimes we can make almost a final diagnosis by just looking at the face. For example, patient with myxedema, patient with acromegaly. We can make almost final diagnosis just by looking at the face of the patient. Then I think, examine the tongue, if there is any thrush, that there is white coating, enlargement, atrophy, fasciculation. I think these things can be noticed even during normal interview. Then lymph nodes, especially the neck. You examine jugulodigestic lymph nodes, cervical lymph nodes, supraclavicular nodes, axial nodes, inguinal nodes, and all the lymph nodes which are normally palpable. They should be examined, and normally lymph nodes are may be palpable in certain areas, but like in axially, lymph nodes may be palpable. In inguinal region, lymph nodes may be palpable. But if they're big and tender, or if they're palpable in an area where they should normally not be palpable, like supraclavicular fossa and this cervical chain, anterior cervical chain, and then I think if they are palpable, that means there is a problem. There could be some inflammation, or there may be some leukemia, lymphoma, and many other conditions. You must note down if there are any lymphadenopathy, and then you see if there is what is the consistency. Hard nodes are typically signs of malignancy. Tender nodes are typically signs of inflammation. Then you must also look at the thyroid. Thyroid may be visible in a normal, healthy young people, but mostly it is not. So if it is visible, then you like to see the size and symmetry. If it is symmetrically enlarged or asymmetrically enlarged, asymmetric enlargement may be seen in thyroid adenoma, thyroid cancer, or multinodular goiter. Symmetrical thyroid enlargement may be seen in Graves' disease and in thyroiditis, and in what is called puberty goiter. And then movement of the thyroid, because if there is any swelling in front of the neck, it should move with deglutition. And also, if it is adherent, it could mean malignant. Then examination of the chest, just the inspection part. We are just conducting general physical examination. I think you would like to see the chest, the shape. A barrel shaped chest will immediately tell you that this patient has got emphysema, and somebody who has got kyphoscoliosis, that should also give you the clue. And then breathing pattern, somebody is breathing comfortably at a rate of 12 is likely to be not very sick. Somebody who's breathing fast, then there are various breathing patterns like chain stroke breathing, Byers breathing, and I think apneic spells, they can be all examined. And then abnormal veins on the neck, on the abdomen and the chest, that would indicate superior or inferior vesical obstruction, or maybe normal in some cases. Then you come to the abdomen, see if there is any distension. Normally, abdomen should be flat, or if there is obesity, it may be protuberant, but it has got a specific shape. Now, if you have abdomen which is distended, then there are various patterns. If it is more distended in the flanks, that could indicate presence of pleural effusion. If it is distended in the center, it could indicate intestinal obstruction. Of course, somebody is pregnant, that of course would cause distension. Then any abnormal veins on the abdomen, that should also be noted. So when you come to the legs, I think you see just the overall appearance of legs, and particularly in the legs you look for edema. And if there is edema, I think one thing you rule out first is the presence of fat. I have seen many women, many men also, who come and complain of swelling feet, but actually it is just fat. So if you think that this is edema, then you make sure, is it pitting edema or non-pitting edema, because the differential diagnosis is different. Pitting edema means when you press against the malleolus, inner malleolus, then a pit is formed. That means there is free fluid in the interstitium. So that causes our nephrotic syndrome, renal failure, heart failure, cirrhosis, hyperproteinemia, and lymphatic obstruction. No, sorry, venous obstruction. Now, if it is slowly pitting, it could indicate lymphatic obstruction, or it could indicate mixed edema. Or if it is not pitting at all, it may be just fat. Then veins, varicose veins are common, and if you have varicose vein, then you need to perform proper examination, and preferably in the standing posture. So I think this is like examining the whole body superficially, right? So I think in majority you have some idea once you have done general physical examination, but then of course you go to the systemic examination one by one. So cardiovascular system, respiratory system, cardiovascular system, I told you, includes examination of pulse and pulses. All pulses should be examined, and in the pulse you study the rate, the rhythm, the character, and the condition of arterial wall, and you also make sure that there is no delay between radial and femoral. These are the things you will be taught in cardiovascular system. Then you measure blood pressure. In some cases, it may be important to check blood pressure in standing posture. A patient complains of postural syncope. First, you check blood pressure in the supine position. Then you ask the patient to stand up, and after patient is standing up for maybe 2 minutes, 3 minutes, you check the blood pressure again. If there is significant drop in the blood pressure in standing posture, that would indicate presence of postural hypotension and can explain patient symptom. This might require further workup or might require some adjustment in the medication. So anybody who is on antihypertensive medication, I think blood pressure measurement in erect posture is essential. Then you come to the neck veins. Detailed I will cover later in separate module, but you must have proper exposure, proper light, and patient must be at 45 degree, and that way you will see the neck veins, and you need to have the ability to develop the ability to differentiate between neck pulsation, venous pulsation, and arterial pulsation. This will be covered in a separate module. So engorged neck veins would indicate increased central venous pressure. Now then you have to see if the pulsations in the vein are present or not. So that will also give you some clue. Then you come to the precordium, and precordium first you inspect, then you palpate, then you percuss. In some cases, percussion has actually not been very popular in cardiovascular system. And then you finally auscultate. Auscultation itself has got then several steps. You examine the apex beat, and you examine all areas and see for any abnormal sound and murmurs. In respiratory system, you count the respiratory rate, and then you see the chest expansion, and then you percuss and see if there is any area which is not resonant. Normally it should be resonant, and then you auscultate and see if the breath sounds are normal, vesicular, or they are bronchial, or if there is any area where the breath sounds are diminished or absent. And then you in percussion see if there is any dullness. I think all these things, and finally in the auscultation you see if there are any rhonchi or crepitation. That would include complete respiratory system examination. Then gastrointestinal system, you first inspect the abdomen, and then you do superficial palpation just to make sure that there is no tenderness. Tender part is typically examined at the end, so that patient does not make himself guarded. So I think you examine the non-tender area first, and then you go to the tender area also. So, and then you specifically look for liver. I mean, if the liver is enlarged or not. If it is enlarged, is it tender, or is it hard, or is it soft, or is it pulsatile? All these things are examined in the liver. And you then measure total liver span, because normally lower edge of the liver coincide with the costal margin. Now, if you can feel the lower border 2 fingers below the costal margin, it could mean liver is enlarged, or it could also mean the liver is simply displaced downward. Like in emphysema, liver may be displaced downward, whereas it is not enlarged. So I think then you percuss the upper part to make sure that upper part is in this normal position. So then you measure you have determined the upper part, you have determined the lower part, then you measure span with the measuring tape. If span is increased, that would definitely indicate hepatomegaly. Then you come to the spleen. Again, spleen, there is a specific method of examination. You first examine in the supine position. If it is not palpable, you move the patient to the right lateral and you use both hands. With the right hand, you are examining the spleen, and with the left hand, you are pushing the costal, the chest forward, so that if spleen is bordered and enlarged, it could come forward and be palpable. There is a specific notch in the lower border of the spleen. If you can feel that, that will make sure that whatever you are feeling is actually spleen. Sometimes you can confuse splenic mass with renal mass or some other mass. So there are certain techniques we use to differentiate between the two. And spleen may be minimally large, which can be detected only on percussion, or it may be moderately large when lower border will be palpable, or it will be massively enlarged where it could go to the right, like fossa. So there is differential diagnosis. So, and then of course, if suspected, you auscultate the abdomen also for bowel sounds. Now, if somebody has intestinal obstruction, you will be able to hear loud sound, and they may be sometimes audible without the stethoscope. I think we call borborygmi. And then we examine the central nervous system, and very interesting and very rewarding, but very lengthy. I think I have already told you higher mental function, cranial nerves, motor system, sensory system, cerebellar system, reflexes, then signs of meningeal irritation, then long tract signs. I think all those should be examined. Then others, whatever system is left, musculoskeletal, skin and appendages, they should also be examined. So I think after this, hopefully we have completed the examination, and you have already taken history, you have now completed the examination, and you might come up with some physical finding. And this is actually, I don't expect you to read through all of them, but this is just an example of what type of physical finding you might pick up. Like bruit is an abnormal sound, then vocal resonance in the lungs, ataxia is related to gait. So all these things, lymphadenopathy, you will note down all the physical findings and then you relate with the history. I think with that you should be able to make a final diagnosis, but in some cases, of course, you need to have laboratory tests. Some tests are done in every patient, but other patients other tests are done only when relevant. So very briefly, I'm going to give you the outline of the laboratory tests we do. I think routine tests, there may be different routine in different setups. For us, I think CBC, ESR, urine complete examination, and routine laboratory biochemical panel, blood sugar, fasting or random, cholesterol, creatinine, uric acid, bilirubin, and ALT. That I believe should be done in every patient who is admitted. And depending upon the facilities, you could actually include others also in the routine examination. And specialized tests, I think ultrasound of abdomen could also be done as a routine, because that also gives you very useful information. X-ray chest may also be done as a routine test. Then there are some specialized tests. They would be done based on the provisional diagnosis. For example, if in the provisional diagnosis you suspect brain tumor, then out of hundreds, CT scan or MRI of the brain would become most relevant. And then the test also decided on the basis of availability. If the required information is possible from CT scan or MRI, so if we have CT scan available, then maybe we will use CT scan. Then cost needs to be considered, but I think there are certain tests they have to be done even if they're expensive, but many times we can do without them with a cheaper test also. For example, if you suspect some mass in the abdomen, you don't have to go for CT scan necessarily. Ultrasound can tell you about the mass. Then invasive versus non-invasive. Now if you want some information which is possible through a non-invasive test, I think we should go for the non-invasive. I'm not saying that we should not do invasive tests. When needed, they must be done. But of course, they are not needed in every patient. Invasive test is the test where we actually invade patient's body with a needle or a catheter or a cannula, and they could be actually harmful, and post patient the safety is very, very important. So I think invasive tests should be done only when necessary, like angiography should be done when you suspect coronary artery disease. So with that, I think you hopefully reach the final diagnosis. After going through history, physical lab, you should be able to make a final diagnosis in most cases. And with final diagnosis, you should be able to give a final treatment. And the final treatment could be writing a prescription for the patient, and could be hospitalization for further treatment, or maybe some surgery, or reassurance, or maybe a referral to some other clinic. So this is how you complete your case. But there's one more component to it. That is presenting your case. You may be required to present a case in the ward rounds or in the examination, and there are certain basic principles of presenting the case. I'm going to outline that also. You may read out from your write-up, but I think best is that you have already gone through history and physical. It would be best if you are able to read out without referring to your write-up. I think, to me, definitely it would be a plus sign if you can do that. But of course, if you are not still expert, then it may be able to read out. But you must be able to read fluently. If it is your own write-up, you must have read it earlier. When you're presenting it to somebody else, examiner or your teacher, you must be able to read it fluently. And read loud and clear, because the other person is listening and concentrating and trying to figure out what it means. And put appropriate emphasis where necessary. Now, for example, you're describing somebody's chest pain, and if the pain does not increase on exertion, you have asked the patient, and you have to narrate that in a very, very assertive way. Or if it is otherwise, that again has to be emphasized. And if somebody has lost weight, you don't simply casually mention it. You put emphasis that this man has lost this much weight, so that the person to whom you are presenting the case gets that registered. Be prepared to answer questions. After you present the case, the examiner or your teacher might have many questions. You have completed the history, but then be prepared to answer the question also. So I think that is presenting symptom. Typical way of presentation is like this. Mr. XYZ was in his usual state of health when. Then this starts presenting illness. Okay. And then the other way is Mr. XYZ is a known diabetic and hypertensive since 2011 and presented this morning with this. Right? So this is another way. Third way is Miss ABC was fine till this morning when she experienced like high grade fever or whatever. So these are some typical ways of starting your presentation, and I think it is a great skill. It definitely is a skill to take history and examination, and it is also equally important skill to present the case. You need to know where to put emphasis and where to cut short, and be able to answer all the questions. And you should always try to make a diagnosis yourself. I think if others are there senior to you, they will help you. But even if you are in the most junior position in the team, you are a medical student, you are a house physician, I think you must always listen to the story and try to make a diagnosis yourself. That is how we learn. And this is how we are still learning. Thank you. This has been Professor Aziz Rehman from Medurstand. That completes our module on approach to clinical medicine. Hopefully, I will be able to do other parts also, and I really look forward to see you in my subsequent lectures. Thank you.